Hello, everybody. We're going to get started here in probably the next 5 minutes, but welcome. Thank you for joining us. We got a full house tonight. I'd love to see the trickle in of folks.
I know that we are in the land of Zoom, but I continue to have this mental image of people filing into a classroom and
Right?
getting settled or a lecture hall or something along those lines. So it's always great.
Yes.
We'll get going right at the top of the hour.
Yeah,
Um,
exactly.
Jannah and I are on East Coast time, so it'll 7 o'clock for us.
Yes.
Adjust your time zones accordingly.
And as you're coming in, one of the things I definitely love to see is where is everyone joining us from? So feel free to drop in the chat, say hi, let us know where you're located if you're on the East Coast like us too. Florida. Okay, yeah. Maine.
Neighbor.
I know. I love
No, your neighbor, not my neighbor.
it. Yeah, Florida, you're my neighbor. Maine is awesome. One of my new favorites. All right. Oh, look. Is that
Oh,
am I saying
Stoughton,
that right?
Mass.
Stoat.
Close by to me. New York City, not too far.
Nice. Some cities I haven't heard of. Is that Macomb, Michigan? That's nice. Jody's in
Now, I'm
Connecticut.
going to give you a little piece of trivia on the state of Maine. Many years ago, I could lay claim to have taught pharmacology to 1/3 of all the nurse practitioners practicing in the state of Maine.
No
That
way.
ship sailed a long time ago, but I had, because I was adjunct faculty, two different universities up there teaching pharmacology.
That's a
Um,
big brag. I like that.
yeah.
Lincoln, Nebraska. I forgot why that came up yesterday in discussion. Lincoln, Nebraska. I have to think about that. That actually came up in a meeting. Now I got to think why.
I taught in Lincoln, Nebraska a number of years ago in February and
Yeah.
had the great misfortune of losing my winter coat on
Oh,
that trip, which I really needed.
no. As a Floridian, that sounds like a nightmare.
It was a little tough. Beautiful city, wonderful people, but somewhere, if you, the person from Lincoln, Nebraska, if you happen to see a navy blue wool winter coat, woman's coat lying around someplace, might be mine. It's actually the airline lost it for me, but that's another discussion.
Oh no, don't get started on the airline stuff. Oof. Oh boy.
So we've got people from all
We
over. This is great.
we do. We do. I love the mix. I love to see where everyone is coming in
Yeah.
from. Very good. Well, I'm excited about this topic. What do you say? Oh yeah. So you already got a question here. Dr.
I
Fitz,
do.
yeah, they read an article they said on from North Carolina State Board of Nursing that said that Mass only allows full practice authority for psych NPs.
That's not true. That's not true.
Okay.
So we'll dispel that. We have full practice authority for all all nurse practitioners. It was a
Okay.
long time coming. A
Okay.
long time coming.
We're going to go ahead and get started. If you just noticed, Brian's our moderator. He went ahead and dropped some housekeeping things, if you want to say in our chat. So I'll just say that feel free at any point while we're having this discussion tonight with Dr. Fitzgerald. You're welcome to drop in any questions in the Q&A box. We have a section for that, or you can drop it in the chat. I'll be checking both spots. And we'll save the last 10 or 15 minutes to go through those questions and make sure that we get those answered for you. So if anything pops up along the way, you're thinking of it, drop it in there. I'll keep an eye on it and make sure that we save a little bit of time at the end for that. So with that said, we can go ahead and open up and get started. I'm excited about this. I love to talk about all things test prep. Dr. Fitzgerald always has really, really good pearls. And I secretly wish I had a time machine that I can go back and be like, I should have done that. That was a good idea when I was on that test. So, looking forward to this discussion, talking about understanding core concepts to score high. And I know you, Dr. Fitzgerald, so you're not talking about we're just going to memorize a bunch of stuff to make sure that we pass the test. We're not any of that, right?
We are in a no memorize, but definitely conceptualize zone here
Yes.
because you're about ready to become a nurse practitioner. And
Yes.
so Jannah and I will kind of go back and forth with a few things here, but let's get the show on the road. So remember that you are now joining the rarefied air of advanced practice registered nurses. Nurse practitioners are only 5% of all of the RNs around. So it really is pretty amazing when you think of what a small percentage we are. It might be a little higher than that now. But one of the other things I want to remind you, as you're getting ready for your NP boards, please, 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 please keep this in mind. Why is it you decided you wanted to become a nurse practitioner? Because right now, as you get ready for boards, you might be saying, whose big idea was this? That's a very, very common feeling to have. And whether you're new to nursing and you did a direct entry program, whether you're somebody like me who was an RN for a number of years before I became a nurse practitioner, it doesn't matter where on that spectrum you are in your nursing career. There was a reason you decided to become a nurse practitioner. My personal reason was I was in critical care. I was ACLS instructor trainer. I was I was CCRN. I was a nurse manager of a critical care unit. I was staff resource. You name it, I did it. And I adored it. I learned to be a leader. I learned to be an expert clinician. And then one day I walked through the ICU, and it was one of the ICUs, a 10-bed ICU. And I looked around and I said, I looked at these patients and I said, this person has preventable disease, preventable disease, preventable disease. This poor soul is just not going to die today, but they're going to die. They're going to die maybe day after tomorrow, something like that. But die they will. Preventable disease, preventable disease. And I said, I've got to do something with my career to keep people out of the ICU. And so that's how I ended up deciding on becoming a nurse practitioner. I'll also tell you, I reluctantly decided to become a family nurse practitioner because the program that I had applied to and been accepted to on the adult gero side, well, back then it was so long ago, there was just plain adult nurse practitioners, then there were gero NPs. What they decided to do, because they had both an adult and a gero NP certification preparation, they decided to close their adult program, reopen it as a family program. So they came back to me and said, you have your choice. Do you want to do family or do you want to do gero? And I knew I liked taking care of older adults, but I didn't want to do just older adults. So I became a family NP. And I said, okay, well, I'll hold my nose during the peds and OB, and I'll never take care of kids and pregnant women ever once I'm out of school. 35 plus years later of full spectrum family practice in primary care, I see kids, I see women during pregnancy, I see everybody that comes through the door, and I wouldn't have it any other way. So one other thing that I do want to mention to you, I am the founder of Fitzgerald Health Education Associates. My clinical practice has been in a federally qualified health center where I just said I do everything that comes through the door. Adjunct professor at Case Western Reserve, which is where I did my doctoral studies. I sit on the editorial board of a number of different publications, and I'm a member of the Pharmacy and Therapeutics Committee for a major HMO in Boston. Excuse me, Mass General Brigham Healthcare. And I'm an author, professional speaker. The only reason I bring all those things up is to just right now, you're really focused on getting through your boards. I want you to realize that the possibilities with this professional change for you to becoming a nurse practitioner, they're almost without limits. And so it's a wonderful time to be a nurse practitioner. So let's take care of this. First of all, as we're getting ready, like Jannah said, put questions to her, to me, into the chat box or the Q&A. And if you're wondering where the Q&A is, if you look at your control bar way over to the right, there are 3 dots there. Click on that, and that's Q&A. And I'm the only one, well, I or John are the only two that can see the Q&A. But I want you to think of something as I'm going through my prepared remarks on what you feel might be getting in your way of getting ready for boards, or a concern that you have, something like that. But what I want to do first is get rid of misinformation and focus on reality. So what's the focus of the NP boards? You know what? Rule number 1 when you're getting ready for an exam is know what the test is that you're actually going to be taking. So are the NP boards just yet another flaming hoop for you to hop through? Is it like a mega final exam for your NP program? Well, it's no and no on both of those. What's the focus of the boards? What have you studied in your NP program? And is that what you're being tested on? Like, think of it as a great big giant final exam, even though you already took one of those. Or were the NP boards developed as a result of a thorough analysis of the NP role in practice? And it's actually the latter. So when you look at the focus of the boards, and the 2 major certifying agencies here are ANCC and AANP, because I know most of you are either family or adult gero primary care NP candidates. And ANCC says that their board certification exam is competency-based exam that provides a valid and reliable assessment of entry-level clinical knowledge and skills for family and adult gero nurse practitioners in primary care. So in other words, the boards are based on practice. What do NPs in practice actually do? What are their roles as clinical decision makers, as diagnosticians, as prescribers, as evaluators of response to care? What does AANP have to say about it? They say that their exam provides a valid and reliable program for NPs to recognize their education and knowledge and assess that entry-level NP knowledge and practice competencies required to provide safe and quality healthcare. Now, you might have heard the naysayers say, well, the NP boards, they're not that hard, and they really don't focus in on what we studied in school, and it doesn't really reflect what NPs are out there doing. Actually, it does. It does. But one of the things is, let's say that, for example, what you want to do in your RN role, you've been working in cardiology. So you always envision that what you were going to do when you got out of school and have your NP boards behind you and you're licensed and all that good kind of stuff, that you're going to seek out a job in cardiology because perhaps you've worked with NPs in cardiology and you've admired what they're able to do and that kind of thing. Great. The exam, if you're family or adult gero primary care, the exam you're going to sit for is not going to look like that specialty or subspecialty, excuse me, NP's role. It's not going to look like that at all. Because what you have to remember is, if you're family or adult gero primary care prepared, you're going to sit for a primary care exam. So the exam that you sit for is not going to look much like perhaps the role you aspire to do. I hope that that's clear to everyone here. So as you're getting ready for these boards, think, I am a primary care provider. And this isn't an hour-long infomercial for Fitzgerald Health Products, but we reiterate that over and over and over again in our family and adult gero primary care board review. Think like a primary care provider. Think like a primary care provider. Okay, so both ANCC and AANP conducted role delineation and practice analyses to develop their exams. From this, they looked at common tasks such as, again, the assessment, diagnosis, plan / intervention were identified, as well as were identified as competencies for entry-level NP practice. And I should have included evaluation there as well. So am I saying that your education is not going to match what's on the NP boards? Is that what I'm saying? So what you studied and what you're going to be tested on, apples and oranges? No, 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 no. What I'm saying is your education has been focused on NP role and clinical decision making, which is reflective of the NP boards. I'm going to say something really bold here. And if you've been on with me for a few other programs that I've done along this line, you might say, oh yeah, I heard her say this before. You're all excellent test takers. How can I say that with a degree of assurity? The reason I can say that with a great degree of assurity is look at you. You have achieved bare minimum a master's degree or a second master's degree or a postmaster's certificate or a doctoral degree or a postdoctoral certificate. Okay. You are an outstanding test taker. Now, taking tests might not be your favorite thing, and I don't think it's anyone's favorite thing, to be perfectly honest with you. But if you want to improve your test taking skills on the NP boards, you know what you need to improve and work on? Your clinical decision making skills. Because that's what this is all about. This is saying once you've passed boards and then you go to your state, you present your RN license and whatever other credentials they want from you, and you get your NP license. What your state is saying is this person has been vetted, has demonstrated that they will be a safe entry level NP in their area of preparation, which for the family and the adult Gero folks is primary care, right? So how do the NP board exam questions, how are these developed? And subject matter experts, AKA SMEs, develop these questions based on the exam blueprint. And the exam blueprint is based on what NPs do in practice, their role delineation. Each question is linked to practice. So you have to think about clinical decision making. That's what this is all about. They're peer reviewed and checked to best evidence. So when you hear somebody say, oh, no, 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 no. Now the boards were loaded with questions where there wasn't a single correct answer. That's incorrect. That's incorrect because they are checked to best evidence. I'm going to give you a quick example of where I hear that about STIs. The CDC came out with an updated set of STI guidelines. I think it was 3 years ago, and it was right around this time. They hadn't updated the guidelines in a long, long time before that. And I'll have people say to me, oh, but I got a question on chlamydia and there wasn't a single correct answer. And I said, well, tell me what you were looking for first-line therapy on chlamydia trachomatis, urethritis, and cervicitis. And the person will come back and say to me, oh, azithromycin, because that's first-line therapy. Well, that was first-line therapy prior to 2022. It was. And now it's a alternative therapy only when it is not possible to use doxycycline and also during pregnancy. So it's not the first line therapy anymore, and it hasn't been for 3 years. So the boards are up to date. And when you hear somebody say, yeah, but there were no correct answers, a lot of times what that person is saying to you is, I actually didn't know what the correct answer was. Therefore, all the answers looked incorrect to me. Each one of the questions will have one best answer plus additional plausible distractors. That's a fancy way of saying there'll be a correct answer and then 3 other answers that are plausible but incorrect. So, in other words, kind of a quick and dirty way of saying this, first line therapy for the treatment of hypertension, right? Person with nothing particular, just initial diagnosis of hypertension. So there might be something like hydrochlorothiazide or a thiazide diuretic. We all know that's one of the first line therapies. Then the other three would all be high blood pressure medicines, but it might be something like methyl-dopa, which is way, way, way down on the clinical decision-making tree, and something we sometimes use during pregnancy for primary hypertension because it has a long-term safety profile, but it's not first line. And then there could be two other, like a beta blocker or an aldosterone antagonist. In other words, the other three choices will all be high blood pressure medicines. It's not like they're going to throw in amoxicillin as one of the possible high blood pressure medicines. But what you're going to have to do is be able to choose the best answer. And if you're ever really confused on what's the best answer, think best evidence. And then the other thing is just go back to the question itself. There likely is some little nugget in the question there that will lead you to the best answer. All of these have been reviewed by psychometricians and peers. There's extensive pre-testing. Every one of you who sits for an ANCC exam will get 25 pre-test questions in your test. They neither contribute to nor distract from your final score. And AANP, there are 15 pre-test questions. So in other words, with an ANCC board exam, you're going to answer 175 questions, but only 150 of those count towards your total score. The AANP, you'll answer 150 questions, only 135 of those contribute to your final score. So just to get rid of a couple of myths in here, I have heard people say, oh yeah, those pre-test questions are either at the very beginning of the exam or the very end. No, 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 no. They're woven in throughout the exam. You will not know which ones are the questions that count and which ones are in there as pre-test questions. So remember, you can get 100% of the pre-test questions right, and it doesn't boost your score. You can get 100% of them wrong. It doesn't make your score go down, but please treat every single question as if it counts towards your final score. And then how are the boards scored? Because there's tremendous mythology about this. Content experts estimate the probability that a minimally competent NP would answer each item correctly. Don't you love that term? This is, by the way, directly from the certifying bodies. Minimally competent NP. That's something to think about. So the AANP, the score of 500 is minimum pass, and that's against a max score or a perfect score of 800. ANCC, minimum pass is 350 against a max or a perfect score of 500. Passing score, these are not graded on a curve, set independently for each exam version, because this is something else to remember. Whereas the NCLEX exam changes itself on the fly according to what your performance is. The NP boards, the exam you sit for was predetermined before you left your home that day. And they only have a limited number of different versions of the boards. Like AANP is really upfront that they have two versions of the family, two versions of the adult general primary care. And that's why if you fail in a calendar year, you fail twice, then you have to wait till the next calendar year to sit for their exam. And so each ANCC doesn't say how many versions they have. And so if you look at this, and this is something I want you to keep in mind, you'll see that there are these assorted predictor exams around saying, oh, if you take this exam and you score here, you're probably going to pass boards. It's indicative that you'll pass boards. And a lot of those predictor exams will tell you if you're scoring in like the mid-60s to about 70% items correct on the exam, that their predictor exam, that you're going to pass boards. Because what people that say that, oh, you only need to score in like the mid to low 60s to about 70% to pass boards. Where they get that 60s to 70% is if you look at 500 as a percentage of 800 with AA and P, that's about 63%. If you look at 350 against a maximum score of 500 on ANCC, that's 70%. But that's not how the boards are scored. Nobody knows what percentage correct you need to get to pass boards. Okay. And there is the only people, well, they're obviously the certifying body. Some people in there know this, but it's only those content experts that analyze the questions and said the minimally competent NP would need to answer X number of questions correct to pass boards. So please keep that in mind. What I like to see people doing is if they're going to do predictor tests, we have tests that come along with our review product. If we want to, if you are going to do a test like that to try to mock up the boards and give you an idea of what the boards are like, I like to see people scoring minimum 80, preferably about 85% correct, because that correlates much more with actually passing the boards. So remember what the domains are for the NP boards: assessment, diagnosis, plan, implementation, and evaluation. AANP mushes plan and implement together. ANCC breaks it down as two different domains on that one. So one of the keys I'm going to give you on key tips on passing the exam is the following. Make sure you focus on which domain is being tested. Is the assessment domain, which is about gathering subjective and objective information. So like health history, history of present illness, objective information, physical exam findings, any available diagnostics. And that's roughly about 25-ish% of the exam. Diagnosis, differential diagnosis. My main piece of advice on you with differential diagnosis: start recognizing patterns. Who most likely gets what disease? For example, on boards, I'm going to tell you right now, one of the most heartbreaking things I ever saw in my life was diagnosing type 2 diabetes in a 9.5-year-old. And yes, it was type 2, it was not type 1. And I even sent him to peds endo that said, son of a gun, this is type 2 diabetes in a 9.5-year-old. Okay. That 9.5-year-old with type 2 diabetes is a big outlier. Who most likely presents with type 2 diabetes? Middle-aged, usually with additional diagnoses like hypertension, dyslipidemia, and obesity, and typically a strong family history of type 2 diabetes. So who's going to show up on your boards? The 45-year-old with a BMI of 35, strong family history of type 2 diabetes. You get the drill. And that's one thing we do in the Fitzgerald review course, is every case is a member of the group who's most likely to have that condition. The plan, always best evidence, and really focus in on first-line therapies. And then evaluation is, of course, response to care. So remember, though, that we kind of throw the words evaluate around to do a lot of different things, but on boards, it's really specific response to care. So general rule, assessment and plan, those two domains together will be about 60% of the exam. then evaluate. Response to care will be about 20%. Diagnosis will be about 20% as well. All right. So this is an example of a question that could look like this is pretty easy. But what I want you to do is to say, where are you in the clinical decision-making process? 29-year-old woman presents with a 3-day history, urea, urinary frequency, and mild suprapubic abdominal pain. She denies fever, vaginal discharge, or dyspareunia with last coitus 5 days ago. Current medications include an LNG IUD, and that's a levonorgestrel IUD. So think something like a Mirena, there Skyla, there are a whole bunch of them for the past 2 years, and reports LMP being of months ago, right? Which of the following is the best next step in her care? All right, so let's take a look at this. Is that she has classic presentation of cystitis, lower urinary tract infection. And you might, I know the emergency room people are doing this already. They're saying, no, 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 she has PID till proven otherwise. But with the absence of fever, vaginal discharge, or dyspareunia, the likelihood of PID is significantly less. She has no chronic diseases. And this is something that can be very, very hard to become accustomed to being comfortable with, but she is using a highly reliable form of contraception with a greater than 99.3% efficacy. And I know, I hear it now, but I had a friend whose Mirena failed. I hear you, but it is almost 100% protective. It is, it truly is, okay? So now here are our choices. Would it be A, prescribed nitrofurantoin? Well, that's the antibiotic macrodantin macrobid. So now what we're thinking, that would be a plan answer, wouldn't it? B, obtain a urinalysis and culture and sensitivity. So that would be an assessment answer. In other words, we need more information. C, order a serum quantitative HCG, which again would be assessment because we're gathering more information. And D, advise drinking at least 16 ounces of cranberry juice per day. That would be, you might say, well, that sounds pretty, like just the kind of advice maybe your neighbor would give you, or you would give your neighbor, or something like that. But that's actually a plan answer, okay? So what's the best answer? It's B, obtain a urinalysis and urine culture and sensitivity. Because with this, you do not yet have a diagnosis. So this was an assessment question. So looking at this and breaking this question down, prescribing the nitrofurantoin, yes, I know that you're now a prescriber and you can prescribe that. And that is typically first line for the treatment of a simple cystitis. But you need to come up with a working diagnosis first. And remember, it's a working diagnosis. It's not like, cast in stone. B, obtaining urinalysis and urine culture and sensitivity. Obviously, that's the best answer because if she has leukocytes and nitrites in her urine, which she probably will if she has a gram-negative UTI, there's a really high positive predictive value for that gram-negative UTI. And then when you've got that, you'll also notice in this question, it doesn't say a darn thing about physical exam on her, does it? No, it doesn't. So sometimes that happens on the boards, right? But what that would allow you to do, if she's got positive leukes, positive nitrites, then high positive predictive value for a gram-negative UTI, you can go ahead then and prescribe the appropriate antimicrobial therapy, which probably would be nitrofurantoin. That would, because that's like first line, right? Now, C, order a serum quantitative HCG. I know you want to order this. I know you do. First of all, there are a couple of things with this. First, note, it doesn't address anything about her chief complaint, does it? So it's kind of like, oh, okay, we're ignoring the fact that it hurts to pee, and she's had this lower abdominal discomfort. She's urinary frequency, but I'm going off in another direction, and I'm going to work up her amenorrhea. Does that sound like a very good idea? No, no. The other part is amenorrhea is very common with the use of levonorgestrel IUD. And that the majority of women, and I mean, when I say majority, I mean over 50%, by the time they have a levonorgestrel containing IUD in place, they are hardly ever having periods, and upwards to 50% simply stop menstruating. They do, because what the levonorgestrel does is it thins out the endometrial lining of the uterus. And with thinning out that endometrial lining, there's, because it's a progestin, there's no menstrual flow to develop. And then looking at D, advise drinking at least 16 ounces of cranberry juice per day. It's not evidence-based, although obviously if somebody's got a UTI, you want them to increase their fluid intake. But there really is no evidence that cranberry juice is going to be helpful for the prevention or during the treatment of UTI, right? So sometimes you're given the diagnosis and then expected to fill in the assessment. A 40-year-old computer programmer presents for a sick visit with the chief complaint of a 2-day history of low back pain. He reports the pain started after a many-hour stretch of doing yard work. The pain is described as a dull ache, worse with activity, better with rest, across his lower back without radiation to the legs. He denies leg weakness, tingling, numbness, and states he had similar pain after doing extensive lifting. In consideration of the diagnosis of lumbar sacral strain, which of the following would most likely be noted on clinical assessment in this patient? So a few things to break down here. You might think, yeah. Pertinent negatives. Yeah, no leg pain, no tingling, no numbness. Yeah, okay, throw away. No. That's a negative neuro exam among somebody with low back pain. So when you're thinking of low back pain, there are two big things. Lumbar sacral strain, which we're being told he likely has, which this is right out of the textbook, what lumbar sacral strain sounds like. And then there's lumbar radiculopathy, and there's neuro involvement with that one. So which of the following would most likely be noted on clinical assessment of this patient? Would it, so background information, lumbar sacral strain, it is a disease that defines itself, okay? It's often triggered by unfamiliar work. You'll hear something like this. I was out doing yard work. We moved over the weekend. Now my back's killing me. You know, there's something along those lines. In other words, somebody was doing work they usually don't. The pathology is of lumbar sacral strain. Always. When in doubt, go back to the pathophysiology of the disease. It will tell you how it's going to present clinically. The muscles and ligaments of the lumbar sacral region have been overworked or excessively taxed. So what are the choices? A, diminished to absent lower extremity DTRs. B, patient report of new onset difficulty with voiding. C, paramuscle spinal tenderness. D, positive straight leg raise test. So this is a good example of how there's one correct answer and then 3 plausible answers on this one. So let's break this down. Looking at A, the diminished to absent lower extremity DTRs, that's an abnormal neuro finding. It's likely lumbar radiculopathy. We're being told he has lumbar sacral strain. B, new report, patient report of new onset difficulty in voiding. That's it, again, abnormal neuro, think cauda equina issue. The paramuscle spinal tenderness, best answer, as I said, the disease defines itself. Positive straight leg raise, not a good choice. That's nerve root irritation and likely disc herniation, right? So C is the best answer. Now, what are we going to do with this aforementioned patient? What's the next best step? So now what this is saying is, do we have enough? We've been told what his diagnosis is. Do we need to do additional diagnostics, or can we go ahead and treat him? So next best step, A, would it be lumbar sacral X-ray? B, lumbar sacral MRI? C, referral to PT? Or D, a short course of a systemic corticosteroid? So one more time with what I said before. A and B would actually be assessment answers, because it's saying, yeah, I'm pretty sure I've got a diagnosis on him, but I need to back it up with a few other things. And then C and D are actually plan/intervention answers, aren't they? So then what you have to say is, well, do I need any specific diagnostics with lumbar sacral strain? Right? So next best step, remember, we've got a diagnosis. Does he need a back X-ray? No. No trauma history. No bone fragility history. He's not a 90-year-old who sat down too hard and now her back is killing her. You know, she could have a compression fracture from just doing that. So, and remember, don't do a test that doesn't contribute to your diagnosis or treatment plan. Lumbar sacral MRI with low back pain. When is this done? Only with radiculopathy signs and symptoms, and usually only after 4 to 6 weeks of conservative therapy. C, referral to PT is our best answer, because that's what's going to help him out with appropriate analgesia, ice, heat, whatever works for them. And D, a short course of a systemic corticosteroid. You'll see it done, but it's not best evidence. So long and short, on that one, C was the best answer. So one, again, you might have heard me say this in other sessions, but I just want to hit a couple of things again, and then we're going to go into what to do on game day, what to do in the 24 hours before you sit for your boards. Okay, the boards, not at all similar format to the NCLEX exam, as I said before. The number of questions are same for every candidate. The exam content was predetermined prior to the candidate starting the exam. 175 questions for ANCC. You get 3.5 hours, a question per minute. That would give you 35 minutes to review highlighted questions. If you're stuck on a highlighted question, highlight it, move on. AANP, 150 questions, 3 hours, 180 minutes. So then you have one question per minute, 30 minutes to review the highlighted information, any highlighted questions, and running out of time on the boards is seldom an issue. So one more time, just remember, you're allowed to mark questions to go back to them for later review. I just can't stress that enough. It really does not resemble NCLEX at all. So you will highlight more questions in the early exam, less as the test goes on, because your brain will have warmed up. So now this is the next thing. People will say, oh, if you highlight a question, should you answer it or not answer it? My feeling with it is answer it, because just in case you do run short of time, after I just finished telling you people hardly ever run out of time, but just in case you do run short later on in the exam, if you don't answer a highlighted question, you have a 0% chance of getting it correct. And if you answer a highlighted question, chances are you were down to 2 choices, you know, and you have bare minimum a 50-50 chance of getting it correct. All right. And by the way, the certifying body does not handle the highlighted questions any differently than they do questions you don't highlight. All right. So how many questions do I need to answer correctly to pass boards? I want you to stop asking yourself that question, because that's a failure mindset. And I want you to think a success mindset. I can't say that strongly enough. All right. So you are being tested as an entry level NP, most of you in primary care. You're not being tested as an experienced acute care RN. And that's why when people say, oh, you need X number of years of RN experience before becoming an NP, or you're not going to transition to the role. Well, you know what? I was somebody who was an RN for a long time before I became an NP. I don't regret it for a minute. I learned a lot about dealing with families in crisis. I learned a lot about a lot of different things. It didn't really influence my ability to clinically care for patients as an NP. It didn't. And I was in the ICU. For the love of God, I was running the ICU. But the NP role is so different than even the experienced acute care RN role, which is what most of you are. All right, so what works best to prep for a high stakes exam? Develop a multi-week study plan. Need I say more? Cramming doesn't work, okay? And what I want you to do is, this link here is on the FHEA website. And I know that you're not looking at the live link, but if you just Google that, it will come up. With each topic, learn about the how, what, and why of clinical practice. And remember that you always need to know why you're doing what you're doing. You are a diagnostician now. You are a prescriber now. So what do I often hear from people who have failed boards? Often they're approaching questions from a low knowledge level, expecting many recognition questions on boards. And here's an example. We have a 25-year-old woman with a 10-year history of 4 to 5 migraine days per month, typically relieved with the use of high-dose ibuprofen at headache onset. I just have to say this as an aside. Any medicine to get rid of a headache, regardless of the headache type, migraine, tension type, always, always, always works better if it's taken at the beginning of the headache. Okay, she denies new headache features or head trauma. She states, I miss at least a half a day of work every month because of these headaches. Neuro exam is unremarkable, right? So which of the following is the next best step? And you might say, wait a minute, I want to know more about her. I want to know more about her. But you actually have enough here to proceed and answer the question. So first of all, 10-year history of 4 to 6 migraine days per month. What probably happened when about 10 years ago? Well, she was about 15 and she probably had hit menarche. And that's often a time for onset of migraine is with menarche, okay? And she has headaches. Yeah, she needs to take high dose ibuprofen, and she really has a lot of days a month of headache, but no new features, no head trauma. So that is a reassuring headache history. When the person is having the same darn headaches over and over and over and over again. So which of the following is the next best step? A, order a head CT with contrast. So what would that be? That would be an assessment answer, would it not? Okay. B, add a triptan dose with each headache. Well, that's a plan answer. Okay. C, prescribe a trial of propranolol, beta blocker. And D, refer to neurology. All right. So one of these is an assessment answer. We need more information before we can do anything for her. That's the head CT. And the other three are actually plan answers. Okay. So let's take a look at this. Order the head CT with contrast. It's not indicated and stable, though very poorly controlled migraine, but you've likely seen this done, right? And if you're saying, yeah, but couldn't she have a brain tumor? Well, God bless her if she's been growing a brain tumor for 10 years. She'd be incredibly neurologically impaired. She would be. Plus, remember, brain tumors seldom present with headache. They present with new onset of an abnormality in the neuro exam, an isolated seizure in somebody who's never had a seizure before, something like that. Would it be B, add a triptan dose with each headache? Now, here's what happens when people are operating from a low knowledge level. Migraine and triptan, those two match, don't they? Read the question. Every word in the question is important. This woman has great headache control with ibuprofen. What do we give triptans for? Is to help with management of migraine symptoms, right? She's doing really well with a cheap med. Leave it be. And it is a migraine specific med. But she has relief with her current therapy. Now, in real life, I might dig a little bit further because what the triptans don't get rid of headache as well as ibuprofen. Don't that beat all? But what the triptans are really good at is getting rid of non-migraine symptoms. I'm sorry, non-pain symptoms like photophobia, phonophobia. So a lot of times when I dig in with my migraine health history, I find out, this person would actually benefit from that, but that's not mentioned in this. So we're going to push that to one side. Would it be prescribe a trial of propranolol? Best answer, because it's one of the first line therapies for migraine prevention. And then refer to neurology. This is more appropriate for new features in migraine or failure to respond to first and second line therapies. So not the best answer. C is the best answer. But you can see once again, the way this question is constructed, all four of the answers are potentially germane to what's being presented. All right, so now let's move on and wrap up here with what to do and not do just before the exam. So, okay, sorry, I forgot to take this slide out. Adage, if you change your answer on an exam question, you probably will change it from correct to incorrect. We've heard this. I swear, people think it came down from the heavens on stone tablets. All right, what's the evidence? If you change an answer on an exam question, 50% of the time, you'll change it from incorrect to correct, folks. 25% of the time from correct to incorrect. So you have a 1 in 4 possibility of doing that. But the other 25% of the time is from one incorrect answer to another incorrect answer. So in other words, if you are drawn to change the answer on the exam, you've highlighted the question, you go back to it, read the question 3 or 4 times, okay? What I would advocate you do, look at the question, highlight the verbs, because the verbs direct the action of the sentences. I know that's a very old school phonics thing to talk about, or grammar, I guess it would be. And then try to figure out, is it assess, diagnose, plan, or evaluate question, and then make your decision on whether you're going to change your answer or not. So please, please remember that this information that's rolled around, that if you change it from correct to incorrect, it's utter nonsense. It was based on a single study done in the 1940s. That was even before I was born, right? So 24 hours before your test, you study, don't study, what have you heard? All right, so here's me. If you said to me, oh, no, don't study 24 hours before the exam. Relax, have a glass of wine, socialize. I'd be the person on the left-hand side of the screen, rolled up, maybe fetal position, and going, no, let me study some more. I could never be the person on the right-hand side of the screen for the 24 hours before the exam. As a matter of fact, I'm getting a little anxiety thinking about not studying before an exam. But you do you. There is no right way of doing this. But I would be rolled up in a ball on the floor if somebody told me you couldn't study ahead of time. Last time I took a major exam, and it's been a while, There was a period of time where nurse practitioners could sit for the medical licensing exam. No, we didn't get them licensed to practice medicine, but we could. And it was a 2 day long exam, and it was pretty grueling. And I literally studied till the moment I sat down in the cubicle both days of the exam, literally. But that's me. This is something, though, 24 hours prior to the exam, don't be stupid, be sensible. Nothing new on game day. I've heard it all. Oh, I tried Red Bull for the first time because my classmates told me it would smarten me up before the exam. And then I sat there during the exam shaking like a leaf. No, no, no. Just don't do anything new on game day. The basics, do a trial run ahead of time, find out where the test center is, parking, public transportation, make sure you don't show up without your ID, etc. You look it up. They're going to tell you what to do. Eat something, a light, nutritious meal so that you don't get hungry in the middle of the exam. Please remember there are no breaks during these exams. Appropriately hydrate, but don't overhydrate, because if you need to get up to pee, it will take time away from your exam. Use a relaxation technique that works for you, box breathing, positive messages. Remember what you put into your professional development. Just give yourself a great big pat on the back. Great big pat on your back. During the weeks prior to the exam, when you're doing you're studying, develop a sheet of topics that caused you challenge. And remember, this list should get shorter and shorter as time goes on. And then consider taking whatever your final list is with you to the test site for last minute reassurance if there's a delay. Every now and again, these test sites, they'll say, oh, there's a little delay in loading the exam or whatever, and you might be able to sit there. Now, they probably will have made you lock up your phone, okay? Because you can't take anything into the test cubicle except for you and the clothing you're wearing, okay? But you probably can get away with having like a sheet of paper that you throw in the trash on your way in. Remember, this is a time to protect the knowledge and its application that you've gained, not try to cram more. And just remember, think like an NP, a clinician who's a diagnostician, a prescriber, and evaluating of response to care, and not like the smart RN you are. And I don't say that with any insult to the RN role. None. As a matter of fact, tremendous, tremendous admiration for what RNs are doing these days. But now you need to think like a nurse practitioner. My book, the 7th edition, came out just a couple of months ago. We do have that available at FHEA. That's going to be great as part of your study too. And we've got online tests with this and learner-friendly features, built-in knowledge and clinical skills building, test-taking strategies, plus, of course, the Fitzgerald review courses. So questions or comments?
That was
All right.
great.
Jannah, what
Yeah,
was your thought when I said, oh, if you change an exam question, you do it from correct to incorrect? What was your thought on that one?
I was making a mental list of all the people I need to apologize to for going back and doing that. Because you're right, it is something that I have carried around forever and have shared forever that not to do that. Go with your first answer. Your first answer is right. But I'm glad that you shared that because you know what? It validates that sinking feeling sometimes that you're like, I don't really think it's C. I really think it's B, and I gotta go with that. So that was
Yeah.
quite interesting. That was
But you
quite,
know what? I also don't want people doing that quote, trust your gut. No, 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 no. No, 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 no. This isn't, this isn't some magic skill. You've
yeah,
studied for this. You've studied for this. And what I always find when facing a challenging question like that is like when I took the DCC exam, I envisioned myself in the exam room with the patient, and that was enormously helpful.
yeah, that's a good one. And we
Yeah.
have a question from the audience here too. This is a good one, and it's something that we get often. Asking, I'm finishing up my first year of my FNP program. When is a good time to start studying for boards?
Now, and I mean that sincerely. because remember, as you're getting ready for boards, you're honing your clinical decision-making skills. All right. And that's going to help you in your clinical rotations. So start now. Now, what I would, in my book, the Fitzgerald Review Course, great place to start with that. And one of the things that I would say with that is I don't want the boards to get in your way of expanding your mind and appreciating the NP role and all. But it's never, I always say to people, start preparing for boards your first day in school. Just simple as that.
Yeah. Let's see here. We have another question, kind of similar. I'll say, I'm taking my board in September. What do you recommend to study? I have your book, but not the new edition.
Um, I would recommend doing one of our review courses. Remember, our review courses are the only one on the market that are focused on clinical decision making, helping you to hone your clinical decision making skills and work on building your clinical knowledge, your differential diagnosis skills, etc. So that's what I would recommend doing. And then go to that article that I have, and it shows you how to kind of blend this all together.
That's a good one. Another one here. I can answer this. Well, yeah. Does your student package allow access to available review sessions, including online reviews? Yes, if you're talking about our student membership, it does. That does give you access to our reviews, which include online and on demand and on site. So yes, I would
Right.
recommend that. One for you, Dr. Fitzgerald. Do you have any recommendations? I graduated several years ago, never took the boards.
Okay, start with, I know this sounds incredibly self-serving. Start with my book, start
Mhm.
going through that, and take one of our review courses. And here's the other thing. I want you to check first, though, do you still qualify to sit for boards? And so check with this with certifying bodies, and they both have the same requirements, so it's not like one is easier or anything like that. They're really quite consistent, but I want you to double check with them first and make sure that you qualify because sometimes it's an issue that you might not have a transcript that reads the way that they want transcripts to read now. So anyway, that would be a good thing to do.
Okay, good advice there. And just real quickly before we wrap, we have a couple more questions, but Brian did drop some links in the chat. So if you're looking for different
Excellent.
free resources and things like that that we have on our site to help you prepare, please take a look at that. You got a great compliment. I love your podcast. They're a great way to break down
Oh,
information and learn. Yeah, I like that.
oh, yeah. How quickly I forget because I've done all 100 whatever of them. The Q&A podcasts where I do they're about 15 to 20 minutes long each. I take an exam question, I break it down, I give a little bit of background information on whatever the diagnosis is, et cetera, or whatever the treatment is, and the feedback's been tremendous.
Yeah, it's been great. It's been fantastic. And then it looks like we got one more here. How do you choose which certification exam to take?
Um, and it it doesn't matter. It really doesn't. What some people would say is something along the lines of one is better recognized in academia than the other. And I'm not even going to say which one. All right, I'm not even going to say which one. Um, because that ship sailed a long time ago. And what I mean is at one time there was one of the exams that people would say, well, if you're going to be in academia, it probably is a better choice. But that was when the other certifying exam was brand new. And ANCC has offered certification for NP since like the late 70s. AANP has offered it now for, I think it's going on 30 years. So in other words, it wasn't just yesterday.
Yeah, yeah. Now we have a couple of questions about the book. I'll jump in for that. the book that Dr. Fitzgerald showed, that doesn't come with the review that we have. We do have a workbook for that, but it is something that we absolutely recommend. And someone asked, is it how different it is from the previous version? I always tend to really want the updated versions of these types of books because the exams update, right? Like as they
Yeah, it
update
is.
cyclically, so does the information that's in there. Would you agree?
I would agree on that one. Yes.
Yeah. All right. And then final one here. Someone's asking that they graduate in October. When do you recommend to take the boards after graduation?
I would allow yourself a good solid minimum 6 weeks of study after graduation. Now, sometimes some people have a really, really light last semester. Not many, but what I want you to do is have a good solid 6 weeks minimum of planned study and go to the article that I gave the link to, and that will help you develop your study plan.
Very good. Very good. Dr. Fitzgerald, thank you for your time. As always, this was great. A lot of really great information. I'm excited for everybody who's getting ready to take their boards. You guys
So
got it.
I.
You got it.
So
You're
very
welcome.
good. And thank you for everybody. Thank you, Brian. And this has been a lot of fun. Take
Thanks for
care
joining
All
us.
right.
and
Have a
welcome
great
to the
night.
best work on earth.
All right. Thank you.
Good night.
Oh, good night.
Good night, everyone.
Good night.